Good day, Martin. Hey, Martin. Martin.
Hello?
Hello.
Yes, hi John.
Hey, Martin, how you doing?
Yeah, I'm fine. I actually I followed some webinars, but I got in late. I'm a bit busy these days, but
Okay.
so yeah. Yeah, so
Okay.
they had very nice presentations actually from Zambia yesterday. I saw the last one.
Oh, good. I'm glad you liked it. Let me turn the volume on. So are you in Dubai now?
Yes, yes, yes.
Oh, that's good. That's good. Yeah, we have Ben tomorrow on today actually in six
Yeah, we
hours.
have been today, I know. So I'm planning
Six
to
hours.
participate. Yeah, yeah. And Daniel Walsh from King's College, who also gave a presentation yesterday, no?
Um,
Oh well,
what did you say, Martin?
uh, the speaker, the presenter of today's
Oh,
Chinese
today. Yeah,
bi-weekly,
the
he
gentleman that's
also. Yeah, he spoke yesterday.
Yeah, he also spoke, yeah, for NOR.
Yes, yes.
So let me see here what we got today here.
And then there's the Russian meeting as well. So I know a little bit of Russian, so I that's going to be today as well, isn't it?
This one, and yeah, Daniel Walsh.
Yeah,
He's from University of Illinois.
yeah,
Yeah, he spoke yesterday, and he's speaking today. He
yeah.
spoke in Japan yesterday. No, not in Japan. No, it was Pakistan with Noor
Right, right, right,
yesterday, and today he's with us and Ben's group. We've been doing this for a couple of years now, Ben.
right. You've had some contacts with Noor, right? I mean, she also she also collaborates with you, or how does it really work over there?
With who?
With Noor from
Oh yeah,
Pakistan.
Noor. Well, we don't really collaborate. She just puts it on YouTube, and
Oh,
once someone puts it on YouTube, anyone can take it and put it on their website.
I
It's
see. I
it's
see.
hard to explain
Yeah.
unless you know coding, the computer
Okay.
coding, but
Yeah.
you can live stream it if a person like Noor is agreeable to putting it on the internet. Some people
Right.
do not like to put it on the internet. They like to have a small Zoom meeting,
Right.
private,
Yeah.
which I could see that. But there's one gentleman, an Indian neurosurgeon, that has a series every week, every Monday.
Really?
Yeah, yeah, and I'm saying to him, man, if you dedicate so much time, you should televise this on the internet so people all over from India. He's from India,
Right.
but I'm sure he'd get a huge crowd from India.
Yeah.
It's a weekly basic neurosurgery. Well, let me see if I can.
Well,
Well,
there's a bit of a cultural difference as well. So some people are quite they're quite married to the idea of proprietary stuff, and of course in education of the younger colleagues and all of that, and exchange with peers, that concept is a bit difficult, because if we don't exchange ideas freely, then we cannot truly advance our science, I guess.
it's an advantage that you can use, or you don't have to use it, but it's an
Yeah,
advantage. It's
yeah,
like being in neurosurgery and you have a decision to make. You can
yeah,
either make a good decision or no decision.
right.
So it's up to you. You want to make the good decision or you make just a decision to do nothing.
Yeah, yeah.
So I see it all the time and it frustrates me,
What about the
especially,
Latin Americans? Are you still, you used to have, and I kind of participated in some of them, with Nicaragua, with Cuba, with what else? Uh, are they still doing a lot on neurosurgical TV?
no, they have, of course I'll televise anything they want, but there really doesn't seem to be much lately.
Uh-huh.
I could always reach out to them and push them, but I
Yeah,
have enough to do myself. If,
sure.
of course, if they come to me, I'll do it.
Sure.
I'll do it. But
Well, that's the thing, we have been going through in it started really somehow in COVID. That was maybe the only benefit we got out of COVID, is that the use of Zoom and so on just sort of blossomed, and so we had a lot of online meetings. But after a while, all the presenters, I mean, it happens to me as well. You sort of run out of how should I put it, original things to say.
yeah.
And I mean, you can always repeat it because people forget, but It's like once you've said your stuff, then you feel a little bit shy to rehash it and rehash it all the time. I would put it that way. So maybe that's why the Latin Americans feel they don't have much to present right now.
Yeah, well, I don't know whether they, well, I think there's a conception that people think that anyone can do the Zoom, but that's not true. Because if you do a Zoom, you gotta have an audience. You gotta have
Right,
people that come to see it, and you gotta promote it. You gotta put it in groups. You gotta
right,
let people know, and they don't realize that, and they think it's free. No, it's not free. No one's gonna do it. No,
right,
no university is going to do it. No individual like me is going to do it because they have a job. They have better things to do.
right, right.
So, so I'm waiting for them to come around. I'm trying to make it a paid proposition where companies can advertise on the Zoom.
Yeah, I
Uh,
thought in the Zambia meeting yesterday that this Indian lady who
yes,
just presented this Samma microscope, I thought
right.
that was good, and the way she did it, it was kind of brief and informative, So you see the microscope, and if you're interested, you can. I actually typed the email address. One guy was asking. I typed it into the chat box.
Well, yeah,
Sales
that's
at
good.
sanma.com, and then a Russian guy or a Russian looking name responded and said thank you, colleague, because that's the kind of thing we need to know. Where do we get
Yeah, the
the
machinery
tools?
and the tool. I would really like to have more webcasts on the tools that people can ask questions about
Yeah,
and maybe give insights
yeah.
onto alternative tools to what they're talking about or what they use. That would
But
be a good center of
yeah, but
discussion.
you see, John, as you, I'm sure you perfectly well know that the pharmaceutical industry, they have big money and they're pushing the most expensive stuff they have, like in
Yeah, yeah, I'm trying to get them to tell
yeah,
because
but they're pushing their monoclonal antibodies, which they are now using. I'm following a bit of other stuff than just neurosurgical stuff because I want to know what's going on in medicine overall and how it might affect us in neurosurgery. So the monoclonal antibodies, they're being used as an adjunct in chemotherapy these days, and they have but they're horribly expensive. They're horribly expensive, and they use them. They know that certain tumors have certain biochemical pathways that they can block with the monoclonal antibody for a while, usually because the tumor keeps mutating, and then the effect goes away. And so they're pushing that, but we're talking one shot like $2,000 minimum, and so the audience in the emerging world, as they like to call it, or just like in the majority of countries cannot afford these kind of drugs. So that's one reason maybe the pharmaceuticals are not so interested. And the other thing is, like you can get aneurysm clips and all sorts of tools, for example, from Brazil. Brazil has marvelous, spinal instrumentation and all of this, but it's not somehow worldwide accepted. The Chinese do as well. You can find aneurysm clips for as low as $1 or $2 on Alibaba if you order 100 of them. But the industry is pushing more like endovascular devices, all of which are beautiful, but you're talking not only thousands, sometimes 10,000s.
yeah,
So that's why maybe I don't know whether one could motivate them to come out with special things that would suit a worldwide audience. I don't know how that works. Yeah, I'm a bit skeptical about them
X
taking a big
hours.
interest.
Oh, man. Martin, the time changed in Zambia. I can't believe it. It
Really.
changed. Man,
So
you
we
gotta
have to
watch.
log in an hour later or what?
Yeah, yesterday they must have had a change of 1 hour because I was sure it was 7 hours difference between here and Zambia, but I
Mm.
just looked it up and no, it changed an hour. So we start in 45 minutes at least.
All right. Then. Well,
Yeah.
let me log off. Then it was nice talking to you. And I don't know, one if I could facilitate that, by the way, if you're interested in getting sponsoring money, I do have contacts, and like the Indian pharmaceutical industry, they're making a lot of generics which are not available in the West because of intellectual property, or it's quite opaque how it really works. But like Indians here in Dubai, they often get a relative to buy the drug in India and then bring it over here because
Right.
The UAE is adhering strictly to US policies, US
They don't have
insurance
big
policies.
taxes and stuff.
Yes, 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 yes. And now you're venturing into Africa, which is I think that's marvelous. But again, these guys, I mean, they now have all these nice looking buildings in Luanda, like in Zambia and other places. But when it comes to the population, we see this here. The population is underinsured. They cannot really afford the modern medicine
Yeah.
unless it is, yeah, they cannot. It's as simple as that. And I don't know what these Latin American countries are doing, like Nicaragua, Cuba, and whatever.
We're trying to
But
get
they
them
have,
involved. We're trying to
yeah,
get them involved, Martin, to sponsor conferences. I wasted years trying to get societies and universities to pay for the conferences. They just don't have the money. The people that have the money are people in medical devices, pharma.
yes,
They have money and they used to paying for education. They've
yeah,
done that forever. They've
true,
sponsored conferences.
true,
So I'm
true.
trying to get them to sponsor Zoom now
Hmm.
rather than going to, it costs them like 50,000 to go to a conference to set up a booth and
You're
to bring
right,
the people there. Now
right,
they can go to a conference online for much, much less, for
true,
less than $500. And they can
right.
interact with people, educate them, network with them. They're going to find, I think if I hold tight and try to get sponsors, that will be the best thing. And
I
then I
don't
can
know what,
approach people. I can approach people like you and
yeah,
say, Martin, I have a sponsor that we want to televise you. It's easy
yeah,
for you. If I
yeah.
go to you and say, Martin, would you like to speak? By the way, can you pay me? That
Then
doesn't
I'm
work.
I'm
That
I'm
doesn't
not really
work.
motivated because that's never been the tradition like that. Right. Yes, yes,
I
you
would
are right.
much rather approach someone and say, we have a sponsor for you. We
Mm,
want to
mm.
televise your
Well,
what you're doing.
here locally, I do know some of the distributors
Yeah,
of
Martin,
medical
anyone.
devices, but they are pushing stuff by Medtronic, they're pushing stuff by Esculap, by
Yeah,
Size
yeah.
or,
Well, anybody that I'll be glad to show them, and I'd be glad to give them a free trial to see,
but
so they can see what
yeah,
it's like.
yeah. And so they like to put up the local distributors are then representing these bigger kind of global companies in their booth,
Well,
and they like to,
do you know
yeah,
the QR codes, Martin? The QR codes,
of what?
the scanners.
Yes, what about them?
Okay, we can use them for the vendors to scan so they can go into a lecture of the vendor. They can go to a website. They can go
Right,
to a private meeting
right.
with that QR code. So it makes advertising more powerful on the internet and makes it more interactive for the advertiser. I'm trying to convince the advertisers and I have two now that I'm showing. They're doing the ones you've been seeing. I'm showing it. They're giving little demos after the webcast, and they're answering people questions, and they're taking, like you were in there, the email addresses and stuff. They love that.
Yes, of
That-
course.
That's their
But then
job.
their problem is to find the audience, that it's always the same, there is always a clientele out there, but how do you reach them?
Yeah,
And
we'll try.
nowadays, Google has sort of, monopolized the kind of, in an odd way, the whole business. My father was running an advertising agency himself, and my uncle was also in the printing business in Germany, and they were like the big newspapers, but everything has gone on the internet, and basically it's gone to Google. And Google is, I don't know, Google is a blessing and a curse. You get my point, no?
Yeah. Yeah, well, they're getting challenged by Microsoft. Microsoft is strong in AI, and
Uh,
Google, I think, is scared for the first time ever, uh,
right.
because they control so much of it. But now they're getting challenged.
I don't know, like John, I don't want to sound too much conspiratorial, but do you actually know the background of all these companies? I mean, Bill
Yeah,
Gates,
it's
Bill Gates,
interesting.
he was never good in programming. It was Alan something rather who was the boy who did it, and his mother was on the board of a big bank, and they had like with IBM, and they gave him and okay, uh, Bezos from Amazon cloud business, right? Bezos' grandfather was a DARPA, like director, the Defense Advanced Research Project Agency, the ones that really gave us the internet.
Yeah,
And the internet still 80% is running through a place south of Washington, D.C. called Ashcroft or something. It's full of data centers. Because 80% of the global internet traffic runs through that place. So
yeah,
they can milk all the data. So that's Bezos, and so his grandfather was in that. And what else? Google and Facebook, all of them. The DARPA, they had a project to call it My Book or something rather, and then they gave it to Zuckerberg. I mean, none of these guys are really, really independent from they're not really market phenomena. This kind of monopoly has come by collaboration with the big government and the hidden government. I mean, that's my take on it. So it's very hard to break through that.
yeah.
Uh, and the competition between Microsoft and Google is and Apple and whatnot is something like the competition between Pepsi and Coca-Cola.
Yeah, well, it's better for the consumer. They're really trying, they're pushing, they're trying for new stuff, trying to make their products better. The
Uh,
consumer benefits.
yeah.
Benefits a lot. When
Yeah.
Google's number one, and they don't have competition, they won't really push as hard, I don't think.
True, true. But I remember the days when we still had, like other search engines like Alta Vista. And I mean,
Yeah,
Google.
Excite and Excite. What were the other search engine?
Yeah, yeah.
Link,
Yeah,
Link. Remember days of
remember that?
Links?
Yeah,
Expedia, not Expedia, but
yeah, yeah. And you
uh,
see, Microsoft was so
Alta
avaricious.
Vista. Alta
Alta
Vista.
Vista, yeah. And Microsoft was so avaricious of pushing any other browser out of the market by coupling its basic Explorer and making it into an internet browser. And I mean, before we had the what was that? Netscape. Remember Netscape?
Yeah. Medscape. That was that still may be around. That was a
Netscape
medical site.
yeah, it has been reincarnated into Mozilla Firefox. That's what it is.
Oh, Yeah, that was the main source of medicine.
Yeah.
Well,
Anyway, so I don't know. I mean, I would love to see you getting as big as Facebook. I'm also sometimes I'm following a little bit, you know, these people from Seattle Science
oh,
Foundations,
yeah,
Sweden,
excellent.
and Rutgers is trying to do something, this and that, and yeah, I guess you know,
I think the best on the internet are Seattle and Barrows. Which
Barrows is also doing something. I've never been. I've visited Barrows before as when I was a fellow in Toronto, and
oh, you
yeah.
were there?
Oh yeah. I know them. I knew Spätzler and the German fellow there. What was his name again? That the one who did a lot on spine, advanced spine. Uh, yeah. But I'm getting older, John. We're all getting older, and so
Well, now, Martin, I don't know if you don't want to get involved in organizing conferences, but you're welcome if you have an idea to.
yeah. Well, I will check with my local colleagues here what we could do because we
Yeah, see
could.
what you use your organizational skills and your ideas of what you've seen, what you want to do, and we can do
Yeah.
it. We can do it now.
Right. You sound like Nike. Just do it.
Yeah, just do it. We have the opportunity. Now's the time.
Yeah. Yeah. Well. I don't know what will happen. Personally, you know, as I said, you know, like there was a big blossoming of all these webinars, and I think people are kind of getting through a little bit exhausted right now. But yeah,
Okay.
we could also put a local physical conference online with your help, and then get those booth type of sponsors involved and tell them, listen, just sponsor a neurosurgical TV with I don't know what your amount is that you would need, and you know you can come up and say to them, yeah, you can be a platinum sponsor, a gold sponsor, or a silver sponsor, and do it like that.
Yeah, that's possible.
I, I so what I would have to do is I would have to find out who are the next local sponsors of a local conference here, and then get them uh, put them directly in touch with you
Yeah,
at
that
your
would be great.
Hotmail.
That would
At
be great. That would be great. And then when I sit with them, I can bring them around and show them why I think advertising is getting more powerful today than it was
yes,
before. And
yes,
you can interact with the clients directly. And the
yes,
way technology is going, it's going to be more interaction on the computer between you and someone that's far away.
yes,
There'll be
yes.
more interaction. They'll be using your hands with models, with maybe machines, maybe with
Right.
glasses, headsets. Things are going to change. I
Actually,
don't know
that's
what.
interesting that you say that we had a course in London in 2016, and we were like tinkering with virtual reality type of
Way
thing
back
where
then,
you,
huh?
yeah. These things, but it hasn't taken off. It hasn't taken
Yeah,
off.
isn't it funny? They've been talking about it for a little, but I think now it's different. I think now it's things because of AI, everything is improving.
Right.
And that makes the water higher for everybody. It
Yeah.
brings everybody up.
No,
So
yeah, well, what will happen with AI? It is so easy to create boilerplate texts. You know, it's kind of like just if you just put in something you want, and then if it's very specific, you know, it will give you information. Then you read through it, and it sounds okay, and then you just put it into your text. But what will happen is we will get such a flood of publications that nobody will read it. I mean, it's been like that for a long time anyway. I mean, there's
Well,
so
yeah,
much,
yeah. You know,
and it'll
people
get
really,
worse.
yeah, not many neurosurgeons, I don't think, read articles. I don't think those days are here anymore. Maybe some
And,
dedicated older guys,
yeah,
but the
well, I
young
do
kids, I don't
read
think they read
something if I
well.
want to know it. If I have a specific question, I used to go to the library. Nowadays we do it via Google, which again, or NI, what is it called, the PubMed, website,
Yeah,
all
yeah,
that.
AI, Chat GPT.
I
It's
don't,
it's such a good search
ChatGPT doesn't give
engine.
me reliable answers. It gives me beautiful help if I want to just put out some boilerplate text.
Well,
Yeah,
you can make videos from descriptions. You can make a description and a video can be
right,
made.
right. The
Imagine,
videos,
imagine that.
yes. Yeah. I saw some examples of that. It's amazing. But again, I just I see the downside as well, the how trustworthy is. I mean, we have a lot of information out there, which even in the old system is not trustworthy. And it's
Yeah,
gonna get even harder.
yeah.
And to separate, the sky, what is it called, the when you have wheat, and you want to separate the wheat grains from the hulls, I mean, yeah. So to separate what is valuable from what is not so valuable, it's going to get very difficult
Yeah.
anyway. And we're going to get flooded, and we're going to get flooded by videos and stuff. Can you imagine, like if take that video example with the making a video. Okay, so you put into some, not chat gpt, it's other programs. You can find them on Poe. um you type in, here is how to clip my middle cerebral artery aneurysm, and then it creates a video for you, and then you're going to present it. I
Okay.
mean, can you see what I'm trying to say? I mean, as much as it has upside, it also has downside for confusion and plagiarism and falsification and misinformation and all the rest of it.
Yeah, yeah, hold on.
John,
Yes.
I will leave you now. I'm gonna do something else. I will log in later again. Okay?
Okay, I gotta do some stuff here now. Hold on.
Yes, please go ahead. Bye for now.
Okay, Martin, nice talking to you. Hello, Vinod, you there?
Yeah, John, I'm here. Hi.
How you doing?
Yeah. Actually, I'm traveling. Dr. Ajit will be doing the talk. Dr. Ajit will be also there in the panel, I hope. So he'll be doing
Okay,
the
yeah,
talk instead of.
yeah, I don't know what is planned today. There was a couple of scheduled talks, but let's wait. The time changed. I was really surprised. Zambia, it
Okay.
changed from 7 hours ahead to 6. I don't know
Oh,
how overnight. So we don't start for another 25 minutes,
okay.
hopefully. And by that time, we'll have an idea of how it's going to be scheduled. I'm checking
Okay.
with Keith. There's a couple of residents there that are kind of running the show. I guess we have to follow their lead. Now, are you going to give a talk while you're driving?
No, no. Actually, I'll be here, but I think since I'm traveling, my friend Dr. Ajit, he'll be doing the talk instead of me. We work together, Dr. Ajit.
Okay, so you have been
So
talking with
SM, when
them.
things are ready,
Yeah,
give me a message. Just drop a message. I'll be also around.
have you been talking with them as far as
Yeah.
speakers and stuff? So you've been
Beg
talking
your
to
pardon?
them, planning?
I think that see, I'm traveling and the internet keeps on getting low and get disconnected also. So I'll join like after half an hour when the things are ready, right? Okay, John.
What?
Is that okay? Okay, join. Yeah. I'll
I
join after half
can,
an hour. Yeah.
hey, Renan, I was thinking,
Okay.
I can
Right.
remember in Nepal going with you to some building. The internet was terrible.
Yeah.
Remember that?
It's,
Remember that ENT conference? Trying to televise that? Oh, the bandwidth was horrible. It was like, it was so hard to do
oh,
anything.
okay. Okay. Bye bye.
Okay, you
I'll
kind
join
of
it.
come back?
Yeah, I'll come back after 35 minutes.
Okay, I'll be here.
Yeah. Bye bye.
Okay, we start in 20 minutes. Agit, are you there? Oh, you're going to come in. Okay, don't tell me we have someone, a speaker, right? Ajit R.
Okay, can you hear?
Okay, hi, how you doing?
Hi. Good morning from here. And I just want to check whether my slides will work. So, shall I?
Yeah, sure. You want to test? Go ahead. Go ahead. We don't start for another 20 minutes.
Okay, yeah, I will just check whether my videos are working or not.
Okay. Are you trying, Ajit? Are you trying the screen share? Okay, looks perfect. Can you hear me?
Problem with this is the videos won't work.
Okay, yeah, okay.
I'm just looking another
Okay,
method.
go
Can
to,
you share?
yeah,
Can
go
you
to the
share?
video. Go to the video.
So it is not like that. It is not like that. Can you give me a few minutes to check it?
Yeah, go to the video now, please. Why? You shouldn't use Zoom. Don't use Zoom. I don't know why you're doing that. Don't use Zoom. You should be able to screen share without using Zoom. You're already in the Zoom. You don't need to open your Zoom. You already are in Zoom. Okay, Ajit? Please don't open Zoom. We already have Zoom open, and the services are available, but let me direct you on how to use them. Okay, Ajit? Let's go there. Okay, Ajit, how you doing? Are you going to screen share your video? I don't know why you're opening, okay. I don't know why you're opening Zoom. Okay, looks like, let's see if you have that presentation. You have videos in that presentation? Okay, let's go to the video. Okay, looks good. Okay, do you have sound in the video or no? Hello? You need sound in the video or not? Hello, Ajit, do you need sound in the video? Okay, let me try to show you something, okay? Because you're adding another step you do not need. You may have learned incorrectly from the very start.
Can you hear?
Zoom.
Can you hear me?
Okay, okay, I need to talk to you face to face. Put your camera on, please.
Can you hear me?
I can't see your face. I need to see your face.
Oh, yeah.
Okay, now listen, you're doing things the wrong way. You're adding
Yeah.
a step you do not need.
Yeah.
Okay, you're adding you shouldn't have to open a Zoom. Okay, let me instruct you what to do. Okay,
Yeah.
okay, go from screen.
Don't
Go to
worry.
screen share.
Please don't worry. I have already solved the problem.
What's
I can
that?
share by. I have already solved the problem.
You go
Okay.
directly to the presentation. You click on share. Click
Can you
on
hear my?
share, and you
Can you
go
see my?
directly to the presentation. You don't go to Zoom.
Can you see my presentation right now?
Okay, okay, go
Can you
to
see the?
share. Click
Can
on
you see the
share.
Can you see the presentation now?
No, you're not clicking on share. You're not clicking on share. Click on share at the bottom.
Are you able to see the presentation now?
No, because you're not clicking share. At the bottom of the screen, click share. You see the bottom of your Zoom? You see the bottom? There's a share button. Can you see that? You see the share button at the bottom of the screen?
It is on the top of the. I am using an iPad. So
Well,
I am
is there a
sharing
share
the.
button? Is there a share button?
There is a share content button is there, but I am sharing my screen right now. My screen I am
Oh,
sharing.
I don't see it. I don't see
You
it.
cannot see it.
Have you presented it before?
Yeah, I have presented it before. I am sharing the screen, and I think.
Okay, you're sharing the screen now. Okay, now
I am.
now
I am
open your
sharing.
PowerPoint. Okay, go to your Power. Share
Can
the
you see it now?
screen. Okay, you're not sharing the screen. No,
Just a minute. Can you see it right now?
yeah, no, you're not sharing the screen. You're not.
Not sharing the screen.
Nope.
കാണാൻ പറ്റുന്നില്ല.
You could try it this way. I don't know.
Are you able to see my screen right now?
Yeah, well, open up your PowerPoint. Okay, I'm seeing your PowerPoint now. It's opening.
Now
Okay,
it is
it's
okay?
yes, I can see it.
Yes. you
Okay,
see
you're
the
all
video?
set. Okay, whatever you did,
That's the
it's
right
okay,
inferior
because I
cervix,
can
the
see
maxillary
the.
sinus, posterior wall.
You can see the video now?
We have removed that part of pterygopods fossa
Okay,
from
so
here.
you have the voice
And
on
that's
the
a
computer,
pterygoid
on
was
the
drilled.
video, right?
Yeah,
You are
yeah,
seeing
yeah.
the medial.
Okay, now it is, you can see it. Okay,
Yes, yes.
yeah.
Well, whatever you're doing is working, so let's do it.
Yeah, can I start it right now?
Okay, well, let me check with Keith.
Okay.
Okay, give me, I think we're starting, yeah, it's just about now. Yeah, we start in 8 minutes, okay, Arthur?
I will wait.
Okay, Ajit, are you ready to start? Hello, Ajit?
May I start the meeting?
Are you ready to start?
Yes, I'm ready to start.
Okay, I'll let you know. Just give me a minute.
Don't.
In a second.
Don't.
Okay. Okay. Okay, hold on. We're ready to start, right?
Is the screen is audio visible?
Yeah, I see it, but it's not full screen. It needs to be full screen.
Yeah.
Okay, it's not full screen. Okay. Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett of Neurosurgical TV. We have day 2 of the weekend of a conference from Zambia under the direction of Ip Sherian. Today we have Ajit Kim from Kerala, India, giving a webcast of Understanding ICA to Perfect Endoscopic Skull-Based Surgery. Okay, Ajit, it's all yours.
Thank you both for invitation. And about this topic, I just say that internal carotid artery is one of the most important structure in the skull base. We have to tackle when we do a endoscopic skull base surgery. This is because whenever there is an injury to the carotid, it is a very catastrophic event and it's a very difficult one to control, and sometimes we will have to go extremes, and it's a very dangerous situation. So understanding internal carotid artery bit by bit and millimeter by millimeter is very important in the skull base. So, as I said, it is the most catastrophic event that can happen during the skull base surgery. So, I will talk focusing on the two structures, that is the foramen lacerum and the cavernous sinus. These are the two structures I will focus, and depending on it, I will try to explain anatomy with a few operating videos. This is one of the beautiful dissection from Pittsburgh group. It shows all the structures. You can see the carotid here. You can see the pituitary gland here. It's a pituitary gland. This is a cavernous carotid, and this area is supposed to be the paraclavial region. And here you are able to see the almost all structures. This is something third nerve that is going in, sixth nerve going into the Dorallos canal. Whole brainstem is visible with the basilar artery. This beautiful dissection depicts that almost all of the skull base can be exposed by removing the bone bit by bone. And second, this video shows
That's the
this video actually is a
part of
skull base surgery, because you see the posterior wall of the maxilla. That is the pterygoid.
You are seeing the medial pterygoid
we are
muscle
going
there.
into the muscles there, pterygoid muscles there. That's the
This is the
median
median
nerve.
nerve on the right
That's the
side.
pterygopalpian fossa is
That's the
exposed.
V1.
And you see the part of the
That's the
posterior wall
cut
of
end
the
of the
maxilla.
eustachian tube.
This region is the region of the
You are seeing the muscle
eustachian
substitution tube
tube,
there.
that is the cut eustachian tube,
And
and
that's a
you are
pocket to
going
the
to the
upper
parapharyngeal
parapharyngeal
space
space.
where
You
we
have
can
the
identify the
parapharyngeal
carotid
carotid
artery
artery
there,
there.
parapharyngeal carotid artery. Then again,
This
we
is
are
a
going
different
medially.
right?
This is the
This is
paraclavian
right
carotid, and
paraclavian
the
carotid
stump,
artery.
the stump you
And
see
the
here
humerus
is
is
the
moving out like that.
median nerve, and now we are
This
going
is
into
the
the region of the
mandibular status. This is the mandibular
eustachian
stress.
tube, and
Thinking process was
the pointer
removed
is
from here.
always
And
there in the
this is the prevertebral. These are the prevertebral muscles on the
region
right
of the
side.
next we are going to the
Another is the
opposite side.
clivus,
Opposite
lower
side there is a lot
clivus,
of bone there. It is
the
a
clival
nasopharyngeal
muscle attachment
carcinoma.
line there.
So that is the region of the
And coming to the
eustachian
other
tube.
side, this left side.
So almost all areas can be identified while you are doing this surgery. So now I come to the foramen lacerum. Why foramen lacerum is important? Because the carotid artery first is enters the carotid canal in the petrous region, then it goes a medial, anteromedial course, then it curves there and enters the cavernous sinus. In the cavernous sinus, it lies in the carotid sulcus. So before entering the carotid cavernous sinus, it traverses through foramen lacerum and the parapharyngeal area. So this foramen lacerum is just a defect in the bone. There are three bones: clival bone, petrous bone, and the sphenoid bone. This is a confluence of these three bones and the three sutures. That is the this is the petroclival fissure. This is the petrosphenoid fissure, and this here is the pterygosphenoid fissure. All these confluences to form the foramen lacerum. It is not actually. It is not a foramen lacerum. It is a just a gap there. So foramen lacerum is a gap formed between the three osseous structures. That is the petrous apex, the sphenoid bone, the greater wing of the sphenoid bone, and body of the sphenoid bone, and the clival bone. And it occupies actually the carotid artery is the upper part of the foramen lacerum, and the lower part is occupied by the fibrocartilaginous tissue. Underneath the fibrocartilaginous tissue is the eustachian tube. So the foramen lacerum in this medial part is separated from it by the fibrocartilaginous tissue, and underneath it is formed the eustachian tube. And this is one of the picture. When you open this area, is the area of the where the carotid artery enters the carotid sulcus. This is the area of the carotid sulcus. So this area is surrounded by so many structures. And medially, this area is surrounded by the pterygoid base region. And if you go somewhat posteriorly and medially, you get a structure called petrosal process of the sphenoid bone. And this is the petrosal process of the sphenoid bone. And lateral to that is the petrous apex. Petrous apex joins the body. There is a projection from the joining of the junction of the body and the greater wing of the sphenoid cut is the lingual process. This is the lingual process. So these structures surround the area where the carotid enters the cavernous sinus. This area is the area of the carotid sulcus. So the boundaries of the foramen lacerum are petrolingual ligament, basi-occipital bone, carotid sulcus, basi-sphenoid bone, fibrocartilaginous tissue of the foramen lacerum, and lingula form an incomplete bony and osseous canal traversed by the C3 segment of the ICA. This canal is an anatomic entity and should be considered as the rostral extension of the carotid canal. This entity is described as the lacerum portion of the canal. And when we go and exposing the carotid, the transpterygoid approach is very important. Transpterygoid approach is important, and identifying the median nerve. Median nerve is an important landmark by which we identify the foramen lacerum. This picture, this is a intraoperative picture, and you are able to see this area is the paraclavial carotid, and you are able to see a portion of the median nerve. This is the median nerve that is going into the infralateral part of the foramen lacerum. And this beautiful picture shows the entry of the median nerve. This is the median nerve. That is, the median nerve is entering the median canal, and Actually, it is going posteriorly, and it forms reaches the infralateral part of the foramen lacera. And you see here, the pterygosphenoid fissure is an important structure, because this is a petroclival fissure, and this is a petrosphenoid fissure. But another important structure is the fissure that forms between the pterygoid base and the body of the sphenoid. That is the petrosphenoid fissure. That forms a posteromedial course into the foramen lacerum region. So actually, this structure forms a posteromedial course, and here is the Vidian canal. This forms a 45-degree angle here, and this region is the pterygoid tubercle. This is one of the important and a sure landmark where which we can identify the posterior wall of the foramen lacera. And you see, this is where I identified. I will try to make you understand the whole around the foramen lacerum. This is the lateral part of the foramen lacerum. This is the lateral part of the foramen lacerum, and this structure is the lingual process. This is the lingual process, and this is a posterolateral part, and here is the median nerve entering the foramen lacerum, and this is the medial area. So from here, behind the paraclavial carotid is the petrolingual ligament. This is the anatomical dissection. You can see this structure. We are trying this structure. We are trying to remove is the lingual process. Lingual process is a vertical projection from the mandibular front, and this forms in the junction between the greater wing of the sphenoid and the sphenoid body. So it is being removed, and the ligament around that is the petrolingual ligament, which forms the lateral wall of the carotid entry into the cavernous sinus. And this petrolingual, again, you are able to see the petrolingual ligament. This is a lingual process, and here it is a petrolingual ligament. Petrolingual ligament attached to the lateral surface of the petrous apex. This is what we are exposing this area from the lateral aspect. Here we are exposing it from the lateral aspect, and here the carotid artery is mobilized medially to expose the area of the petrous apex here. And the clival bone immediately posterior and medial to the pterygosphenoid fissure forms the medial wall of the foramen lacera. This area of the clival bone. This is the area of the clival bone. This posterior and medial to the pterygosphenoid fissure, and this forms the medial wall of the foramen lacera. And this is a picture which is taken from the Miranda's writing. So this shows us so many structures here. You can see the paraclavial carotid here. You can see the inferior petrosal sinus. This is the inferior petrosal sinus. And in between lower part, you can see the petroclival synchondrosis here. And you are able to see the Vidian nerve entering the foramen lacerum. And these structures, if you go down, you can see the jugular tubercle, and below the jugular tubercle is the hypoglossal canal underneath the occipital condyle. And actually, the importance of this picture is medial to the paraclavial carotid. In between the inferior petrosal sinus and the paraclavial carotid is the petrous apex. Is the region of the petrous apex, and the inferior that is the petroclival synchondrosis. So, when you do a dissection, when you remove the petrous apex, you reach the internal acoustic meatus. You directly reach the internal acoustic meatus. When lower part you remove, you reach the jugular body. And another important structure around this entry of the carotid is the petrosal process of the sphenoid. The anatomical important. This area is the petrosal. This is the open view. This is the petrosal process of the sphenoid bone. And the importance of this structure, when you go from inside endonasal aspect, is after identifying the petrosal process of the sphenoid bone, you are able to identify the sixth nerve. Sixth nerve passes superior to the petrosal process of the sphenoid bone, underneath the cuboid ligament. And you see, this is the paraclavial carotid, which are distracting. And below you can see the sixth nerve over the petrosal process of the sphenoid bone, petrosal process of the sphenoid bone. When you go medial to this, again we are going lateral to the carotid, and the lateral to the carotid we are able to see the sixth nerve there in this area. And this is the ultimate of dissection. So you remove, drill the bone medial to the carotid, paraclavial carotid. You can reach the up to the petrous apex, and medial to that is the inferior petrosal sinus. So by drilling it in a direct way, endogenous way, you are able to see the medial to that by pushing the carotid more laterally. But in a contralateral transmaxillary approach, where you come from the opposite side, which is described by the Carl Snyderman, you have a direct view of these structures, the petrous apex, the petrosal process, etc. And this is ultimate of dissection after removing the petrous apex, after removing the exposed 7-8 cranial nerves, after removing the jugular bulb, you have exposed the 9 ribs. After removing the hypoplastic canal, you expose the 12th nerve. And almost all bone in the skull base can be drilled and removed, and the critical structures can be identified, which is also important in identifying the carotid. This is the carotid, that is the parapharyngeal carotid, and this is where it enters the carotid canal, and this is the petrous ICA. And next, you when come to the cavernous sinus, the petrous, it is divided into laceral ICA, paraclavial cavernous ICA, and paraclinoid ICA. The more important, already I have described laceral ICA. Then there is the paraclavial ICA, and it's also described. Then the paraclavial ICA ends as a short vertical here, and then the posterior genu here. Then it continues as a horizontal segment. Then this is the anterior genu. Then it goes as a paraclinoid ICA. And this dissection shows the structures here. You can see the entry here in the posterior area. Then this is a short vertical. This is the area of the posterior genu. Then the horizontal segment. Then here it comes out the clinoidal ICA. Clinoidal ICA is something between the proximal ring and distal ring. And the cavernous sinus is actually divided into superior compartment, because if something superior to horizontal segment is the superior compartment, inferior to is the inferior compartment, and the posterior to the short vertical is the posterior compartment. And there is a medial compartment, and also lateral to the structures in the lateral compartment. And this is a very important anatomy. Carotid, always the pituitary has inside the meningeal layer. Superficial to that is the periosteal layer. This is the periosteal layer that goes laterally, and this forms the anterior fold. This periosteal line goes laterally and forms the anterior wall of the cavernous sinus. And deep to that, if you go between this and this, there is the medial wall of the cavernous sinus. So the carotid enters somewhere here in the depth, and this part is almost 1 to 2 centimeter anterior to this part. So opening this area is a safe when you open the cavernous sinus. And I come out the paracellular ligaments. The importance of paracellular ligaments is it has got a good relation to the carotid artery everywhere. So the first ligament ended as when you remove the medial wall. I already have shown the medial wall here, because here this area. This is the anterior wall of the pituitary gland, and here is the anterior wall of the cavernous sinus. In between is the medial wall. So if you go deeper and removing the medial wall, you are able to identify the so many ligaments. The first ligament encountered is the inferior paracellular ligament. Yeah, and from the medial wall, it goes into the short vertical portion of the carotid artery. This is a short vertical portion, and this is the inferior paracellular ligament going into there. And the next ligament. So this is one way to identify the short vertical ligament, short vertical part of the internal carotid artery. The next ligament is the superior paracellular ligament. This is the superior paracellular ligament. You can see the superior paracellular ligament that is attached to the horizontal segment of the carotid artery. This is here. So the importance is this: all ligaments from the medial wall get attached to the carotid artery in the cavernous sinus. So this is a superior view of the cavernous sinus, and the topmost ligament is the carotidoclenoid ligament. It is attached from the medial wall to the carotid and go into the anterior under surface of the anterior clinoid process, and then this forms the superior wall of the cavernous sinus. You see, this video shows the innumerable number of these paracellular ligaments. You can see the suction is in the paracellular ligament and it is getting attached to the carotid. So, dissecting this paracellular ligament one by one after coagulating is important. And this picture also shows the innumerable number of these paracellular ligaments. And this video shows how we tackle the bleeding when you open the cavernous sinus and identifying the carotid. Injecting a flowing gel form into that can create a stopping of the blood. One of the another important structure is the inferior hypophyseal artery. It arises from the meningohypophyseal trunk and it traverses medially from the posterior genu. And it has got a close relationship with the inferior paracellular ligament. So, identifying the inferior paracellular ligament and the inferior hypophyseal artery underneath is very important, because if inferior hypophyseal artery is torn from the trunk of the internal carotid artery, it can cause a troublesome bleeding, which is a difficult one to control. So, when you dissect the medial wall of the carotid in isolating the internal carotid, it is essential to identify the inferior hypophyseal artery, coagulate and cut it. Now, about the medial cavernous wall, I already stated where you start the medial cavernous wall, and you can, by step, you can cut and remove the medial cavernous wall. And you can see this is a pituitary which has an extension into the cavernous sinus. So we are trying to remove the medial cavernous wall, and in the depth you are able to see the carotid artery. And after identifying and isolating the medial cavernous wall, it can be divided step by step, initially from the anterior part, then going into the deep, that you can identify and you can cut it by piece. Next is about the clinoidal space. Clinoidal space is a transitional space between cavernous sinus below and intradural subarachnoid space above. It is limited by distal ring superiorly and proximal ring inferiorly. And one of the important structures is the dorsal clinoidal space. It is a clinoidal space located at the posteromedial or dorsal aspect of the clinoidal ICS. Posteromedial or a dorsal aspect of the clinoidal ICS. You see, this is a dissection where you are able to see the interclinoid ligament. Interclinoid ligament is a connection between the anterior clinoid and posterior clinoid, and anything superior to that is the part of the dorsal clinoid space, and the medial to this is the oculomotor triangle. Here, in the dissection, you are able to see the third nerve there, and something underneath that is the interclinoid ligament. Always, sometimes most of what the third nerve is sometimes mistaken for the interclinoid ligament. For the supraclinoid ICA, you can go through the oculomotor triangle when you identify the clinoid space and cut and identify these ligaments. This video shows after the removal of the oculomotor triangle, we are going into the parapendular space, and we are able to see the angus there, and in the upper the dissectrix on the third nerve there. So this is something gone into the clinoidal space where we have to use this technique, and you can see the normal pituitary there, where we are going into the deep area, where we can identify the pecom artery there, and underneath the pecom artery is the third nerve there, and this approach is essential for removing the tumors that go into the supraclinical space through the oculomotor triangle. And this is another video. You can see the third nerve very beautifully there. It is entering into the anterior cerebellar artery, and this is a very essential step for certain tumors that reach there. Thank you for your patient listening.
Okay, very good. Thank you very much.
Hello.
Yeah, can you hear me okay?
Can you hear me?
Yeah, okay, Keith, take over, please.
Okay, thank you very much, Professor, for the talk. Very interesting. Anatomy of the carotid and its branches in the stellar and parastellar region
Excuse me,
is
Keith,
quite complex.
your picture's not on the screen. You need to put your picture on.
You can, just a second, the light.
That's part of the strength of the video platform is, okay, we don't see
Am
your
I
picture.
seeing now?
You need to put your picture on. Oh, okay, I need to.
Okay.
Yeah, we got it.
Great. So I was explaining that quite grateful that the professor had time to present a very complex topic, anatomy of the carotid and its branches in the parastellar and the stellar region, and is quite complex. And most, I think most would admit in Africa are novice to this area in terms of operating in the operating field. So dissecting the carotid is quite prudent and welcome knowledge for us. The first question I have for the professor is, in case of intraoperative carotid trauma, and how would you mitigate intraoperative carotid trauma in the event you traumatize the carotid?
Yeah, actually, this is the purpose of presenting this topic, because the precise knowledge of the anatomy is very essential in working around this region, because you have to learn bit by bit, millimeter by millimeter in this region. Okay, so identifying the carotid first in the foramen lacerum area, then where it enters the cavernous sinus, then inside the cavernous sinus, and in the supraclinoid region, is a very important step. Second, before you go for surgery, you have a good knowledge with the MRI pictures. You just go through all the MRI pictures. You should understand the curves, and you should understand the position of the artery, etc. So third thing is always use a navigation. If it is a recurrent case, it is a must. You should use a navigation or a navigation. The fourth important point is always use a Doppler. You palpate around the Doppler with the Doppler every area, and make sure that there is no artery there. And whenever you are doing the drilling, you use a diamond burr, and always make the bone as a thin shell, and then break it open, or don't try to take it out or pull it out. And another thing regarding preventing the injury is identifying the areas where you have to open, because I have already shown, when you open the cella, the infralateral part of the anterior wall of the cavernous sinus, it's a safe area to open the cavernous sinus. Second thing, when you identify the carotid, you can use the landmark of the median nerve and the petrosphenoid fissure. And the joining of this petrosphenoid fissure is the posterior wall of the foramen lacera. So understanding the carot, and when you come to the dorsal clinoid space, you know about the caroticoclinoidal ligament. Caroticoclinoid ligament, and removing it and entering the dorsal sphenoid space is a very important step in avoiding injury there. Then identifying the inferior hypophyseal artery by identifying the inferior petroclinoid paracellular ligament. So all this knowing anatomy, and second thing, using a high quality endoscope and the specific instruments. These are all the ways to prevent the injury to the carotid nerve. But if an injury happened to carotid nerve inadvertently, what you should know is first identify the area of the injury. You should use a bigger suction. You as if you in a microsurgery, do a good suction and put a good patty over it. And then for the first time you stop the bleeding, and then alert the anesthetist, all the people around, that there is some injury happen, and prepare them for the contingencies like a need of blood and other when they all this blood, everything is ready, and interventional radiology is also ready. So you then prepare the thigh and take muscle from there. Then you can remove the suction, and then you can put the muscle along with the cottonwood or a surgical there and stop the bleeding, and then get the help from the interventional radiologist. They can take directly to the intervention suite, and you can put a stent or you can whatever procedure. Okay.
Okay, that's a lot to take in, but the thing is, I think hopefully next year or any time closer, would give you an invitation to come down here in Africa, so you can actually show us live the dissection of each segment of the carotid.
Sure.
Come through, sir.
Sure.
Did you see the comment?
Thank you very much for the presentation.
Did you see the comment from Dr. Moning? She said, my question is, in your center, how many operations do you do weekly?
Cavernous sinus.
Yes, from the cavernous sinus.
We don't do it weekly. We do 1 or 2 cases every month.
Okay.
Okay.
What type of cases do you do?
Actually, this you have to identify the carotid, because if I will tell you a clinical scenario. If patient with a ACTH secreting adenoma operated somewhere, and the patient still having a high cortisol level, so we did a MRI, and MRI showed that carotid invasion, medial wall as well as it is going into the carotid. So what we do, we reoperate the patient. We open the patient, we identify the medial wall, we remove the medial wall bit by bit, all the ligaments, everything is open, and it is totally removed, and patient become free of this ACT secreting adenoma. Another area is the growth hormone secreting adenoma. They can invade into the clinoidal space. Clinoidal space is usually in the usual surgery. The clinoid space usually is left behind. So after surgery, the rest of the tumor will be there, and it will be difficult for the patient still having a higher secretion of the growth hormone. So we can go to the dorsal clinoidal space and remove the tumor. These are the types of the tumors that invade the cavernous sinus. Is the one type of tumor we do. Another is with a suprasellar extension through the oculomotor trigon, that you can expose through you can approach through this approach. So then about the clival lesions in the paraclival region, clival lesion in the lacerum region. And another is what we go for the transperigoid approach is the trigeminal schwannoma, Meckel's cave schwannoma. Meckel's cave schwannoma is one of the cases where we can do easily with this approach.
Professor, I wanted to find out, in the case of pituitary adenomas, NOPS grade 4 with encasement of the carotid artery, is it always prudent to dissect the cavernous wall and follow it?
A NOS classification actually is a radiological classification. It doesn't correlate with our clinical findings because if in the radiology the NOS classification says who there is some attachment, but it is medial wall is free. But 60 to 70% of cases medial wall invasion in the NOS grade 2 patients. So your question is a very good question because we don't have to remove the medial wall in all cases. Because our principle is whenever we found, first we open the cella, we remove the tumor, and we look for the medial wall. If we see the medial wall pristine and not invaded by the tumor, we don't do anything. And if there is an invasion of the medial wall, if there is something tumor adhering to the medial wall, and medial wall is thickened, then we will remove the medial wall. And second is that when we will have a thorough knowledge of the MRI, we will look in the MR because now the cavernous sinus from the medial side, it is inferior, superior, posterior, like that way. So all these areas except the posterior, which is a very difficult. You have to expose the foramen lacera. We will look in the inferior area, superior part in the clinodal area look for the tumor. If we suspect a medial wall invasion, if the medial wall is pristine, it is not invaded, we will leave it. We don't go for chase the tumor.
Okay. Thank you very much.
Thank you. Thank you.
Okay.
Hi, thank you for the presentation. I'm one of the fourth-year residents. My name is Dr. Morne. I was wondering, are there any opportunities for us as residents to come and rotate and experience some of the operations there?
Actually, telling we are running a fellowship on minimally invasive neurosurgery, endoscopic neurosurgery, but you have to undergo certain government norms here. Because as a fellow, you can observe, but you have to go through the government norms. And if you get a clearance from the India government, you can come and practice here.
Okay, thank you very much.
Thank you.
Thank you. Thank you. Thank you for your invitation.
Thank you very much for your time, Professor.
Yeah, thank you.
Okay, Keith, what's the next presentation? Do you have it ready?
So the next presentation will be done by one of the residents,
Okay.
Dr. Ali.
Okay.
Ali?
Is Ali going to come up? She's presenting from the podium, huh?
Yes, he's coming. Hi, Dr. Bennett.
plan now? Keith, do you know? What's the plan? Oh. Okay, I understand. Well, Keith, we're going to the dissection. What is going on here?
Hello, Dr. Bennett.
Yeah. Okay, what's going on?
I wanted you to make me a participant.
Okay. Are you
Like
gonna make
yesterday.
what are we gonna do now?
Yes, we're going to present.
Oh, okay. Who's next?
Dr. Ali, but you need to make me a participant like yesterday. A panelist. Thanks.
Okay.
Not this one. I'll send you. I'll raise my hand.
Oh, okay. So someone's gonna present now, correct? Oh, there you go. There's your hand. Okay, you're coming in. You're getting okay, right?
Progress. Thank you.
Okay, I believe you're in there, right? Dr. Moaning, I believe you're ready, correct?
Yes, yes. I'm just sharing my screen.
You may have you may have your YouTube open. Or maybe not. Okay, could you make it full screen, please? Presentation mode. Okay, it's not in presentation mode yet.
Is that okay?
No, it's not in presentation mode. It needs to be put in presentation mode. Is that possible? You can see the picture, right?
Yes.
Oh, that's good enough. If you want to do that, that's fine. Okay, Doc, that's fine if you want.
Can you see it? Hi, can you hear us?
Okay, still not in full presentation mode.
Okay, still not in full presentation mode. Still not in full presentation mode.
But it's acceptable. If you want to go ahead, that's fine. There, perfect. You got it. You got it. Okay, all set, Doc.
Okay.
Yeah, I could swear my microphone works.
Thank you very much. We are going to share a transpetrosa approach. Transpetrosa approach is an approach to the clivage area through the petrosa. The petrosa is part of the, as we saw yesterday,
in the previous presentation with Dr. Katambo. It's part of the temporal bone. Next slide. Next slide. So next slide. I like this slide because it's simplistic, but it actually summarizes most of the structures which are passing to the basal skull. So here we have the anterior fossa, the middle fossa, which is our concern, and the posterior fossa at the base. So we can, for a quick reminder of anatomy, here we have in the middle fossa our superior orbital fissure, where we have cranial nerve number 3, oculomotor 4, trochlear, V1, which is the ophthalmic branch of the trigemina. Then we have CN6, which is an abducens, plus the superior ophthalmic vein. So it's important to remember that, so that when we are looking at the approaches, it will be much easier for us to understand. So the next foramina at the base of the skull is the rotundum. The rotundum, we have V2, the maxillary nerve, which is passing there. Then we have ovale. Ovale is got V3, which is the mandibular. Then we have also the accessory meningeal artery and the lesser petrosa nerve, which is branch of the facial nerve. So then we have closer to ovale, we have the spinosum. The spinosum foramen is the site where pass the middle meningeal artery, plus the vena plexus and the meningeal branch of the V3, which is the mandibular nerves. So closer to the spinosum of foramen, we have the carotid artery. I think you can see the arrow. Yeah, so we are talking about the carotid artery there. We can see the proximity of those structures. Yeah, we have the carotid canal where we have the internal carotid there, artery, yeah, the plexus. Then we have at the ridge, the border between the middle fossa and the posterior fossa, where we have the internal acoustic meatus, which is very interesting because there we have 7, 8. So cranial nerve number 7, facial nerve, and the vestibular cochlea passing the same foramen there. So it's important for us to remember that 7 and 8 are actually passing in one foramen. That will be having a clinical significance when we look at the approaches. Then we have our jugular foramen, where we have the inferior petrosa sinus. We have the jugular foramen is divided into 2. We have a pars nervosa and a pars vascularis. The pars nervosa contain 9, 10, 11. That way it becomes much easier to remember. Then the pars vascularis contain the junction of the sigmoid sinus, continuing with the jugular vein. So it's important to remember these structures. Then we have also the hypoglossal there and the foramen magnum. The next slide is showing the part of the temporal bone, as we saw yesterday. It has got mainly three parts. We've got the squamous cells bordered by the temporal up there. In front there, we have the greater wing of the sphenoid and the zygomatic bone. In the posterior, we have the occipital bone. In the superiorly, we've got the parietal bone. And inferiorly, we have the glenoid cavity and the mandibular. So our area of interest is actually the petromastoid area. So because it's at the base of the base of the skull. So the next slide is giving a little bit more details in that area. There we can see the foramen ovale. We said that the foramen ovale, what is passing there? We have V3 is passing there, which is the mandibular branch. We have the accessory meningeal artery there, and we have the lesser petrosa nerve, which is passing in the ovale. Then we can see a structure which is very interesting. You understand why? There's arcuate eminence. It's important to recognize that structures. There we can see the internal acoustic meatus. We said 7 and 8 pass through the internal acoustic meatus. So they are coming from there. Then we've got petroclivus fissure. Then we've got the jugular foramen there with the stelloid, which is dividing the two, the pars nervosa and the pars vascularis, as we said. So this is also giving the same details which we are talking about. Again, there is showing the different part of the temporal bone, the squamous cell, the carotid canal. It's here to notice that the carotid canal and the jugular fossa, they're quite closer. And this is anatomically significant in the petrous part. Here again, we can see we have the mandibular, the posterior root, the petrous part. We've got the foramen lacerum, where we've got the greater petrosa nerve, which is also a branch of the facial nerve. The facial nerve is quite interesting nerve because it gives a lot of branches in its way toward the face. Yeah, so the greater petrosa nerves pass through the lacerum, and we have the foramen ovale there with V3. Then they meet somewhere there. Near the carotid canal. Okay, so give more details. These slides give us the same architect in the base of the temporal bone. So I thought it would be interesting also to see where the nerve are actually coming from. So this is why I put this slice of the brainstem with the upper part, which is the midbrain, the pons, and the medulla oblongata. For me, it has been easy for me to remember them because I realized that 3, 6, and 12, they're actually on the middle. This is something I discovered personally. 3, 6, and 12. So there we have oculomotor, 3, so almost on the middle. Then we have abducens nerve, it's almost in the middle. Then we have hypoglossal nerve, which is a little bit medial compared to the rest of the other cranial nerves. So 3, it's on the middle at the junction with midbrain and the pons. So it becomes easy for us to predict the other nerves. If 3 is on the middle, then the next one will be 4 and 5. That's trochlear nerve. And then we have the trigeminal nerves. Then the next one, 6, is on the middle at the junction of the pons and the medulla oblongata. Then the next one will be 7 and 8 to the side. 7, 8, then 9 is there. Glossopharyngeal nerves. So if I'm told which nerve is there, I need just to go there. I say, okay, 6 must be on the middle. So then that should be 7, 8, and 9. That way, it becomes much easier. So we have the origin of 7 and 8 almost at the same level. Then we have the 8, 9, and 10, and the 11 accessory nerve is quite interesting because it has got a lot of branches which are going even on the spine level. So there's a cervicofrontal root, and there is also a medulla level. So again, this slide, it's showing us the approach actually at the jugular foramina. It shows the relationship between the internal jugular vein, the internal carotid artery, and the origin of 9, 10, 11, 12. So the way they pass, we can see there up there, the cranial nerve, facial nerve passing into the internal acoustic meatus. We have glossopharyngeal together with the vagus nerve, which was cut there, and the accessory nerve, then hypoglossal passing. They are quite similar. What is quite closer? What is interesting is also to see that we have a lot of anastomosis on the nerves. We've got the tympanic branch, we have the nodosal ganglion, communicating branches which are on their way towards the facial areas. So it's in these areas, ambroglios of nerves and vascular anatomy, that we have to navigate to actually reach our objective. So the transpetrosal approach, what is it? It's a surgical approach which used to access to the petroclival area, as we say. It is located at the junction of the petrous and the clival bone. So commonly used to treat conditions such as petroclival meningiomas, chordomas, chondrosarcomas, aneurysm, and AV malformation. So this is the reason why we are going to, in such condition, we are going to use this transpetrosal approach. It involves a craniotomy and navigation through the petrous bone to access the petroclival region. Different variation. So depending on the anatomy of this approach can be taken. So there's no one variation, there are many. So out of many variation, I choose the one which will allow us to access to the petroclival region. So we can have transcochlear approach, translabyrinthine approach, transsigmoid approach. The choice of approaches depend on the location and the size of the lesion, as well as the patient and the individual anatomy of the patient status. So I choose to discuss one of the approaches which they call Kawas approach. There's the modified Dolan-Kawas approach. The Dolan-Kawas approach is when you add the 60%. So our aim is to be how to access to the base of the skull, passing through the petrous. So it's here to recognize our structure we saw previously. There we can see the internal carotid artery there. There we can see V3 toward the overlay. We can see V2 toward the rotundum. We can see V1 toward what? Superior orbital fissure. So they are quite closer structures. And between the branches of the trigemina, we have triangles. It's those space that we can use to access to the petroclival areas. So one of the area which is quite safe, it's called Kawase area. That Kawase area is determined by what we call greater superficial petrosa nerve. A greater superficial petrosa nerve is it's a branch of the facial nerve coming from the geniculate ganglion. So the geniculate ganglion will give the greater superficial petrosa nerve. It will give also the inferior petrosa nerve just from the geniculate ganglion. And it gives also communicating branches of the facial nerves which are going towards the maxilla. The lingual nerves, all of them, they are coming from the alveolar nerves, all of them are coming from the facial nerve, from the geniculate ganglion. So this is an important landmark for us. There we can see the tympanic portion of the same facial nerves there. And here we can see the arcuate eminence at the base of the petrosa. So when we manage to we trace that triangle, it's called Kawase area. That's a safe area where you can actually drill to access to the petroclide area and deal with the problem. The problem, which can be an aneurysm, it can be a meningioma, and that, as we said, here again, it's a schematic way of showing greater petrosa nerve, arcuate eminence, petrous ridge. Then you'll be able to assess to our approach. So here again, it's just emphasizing what I'm just from saying. We have here the trigeminal nerve with its 3 branches, V1, V2, V3, and the posterior triangle. So in between the language, we have the triangles where you can actually access. We have about 4 cavernous sinuses triangles plus 6 middle fossa triangles. So we have like clinoid, anteromedial triangles, oculomotor, supratrochlear, Parkinson, infratrochlear triangle, 6 middle fossa triangles, anteromedial, anterolateral, posterolateral, posteromedial, inferolateral, inferomedial. So all those triangles are actually areas where we can exploit and access the petroclival areas. So here again, it's a schematic which is showing how we actually position the patient. We can do our reverse question mark incision, starting from the triggers of the external ear canal, or we can do horseshoe incision. Then we are on the bone. So our region of interest is the base, basoskull. And from there, once we open, remember that this picture, the brain is actually on top in the real sense. So now when we lift the brain, we're actually now dealing with these structures. So there we have a middle meningeal artery going into the spinosome, which is closer. We know that spinosome is closer to what? To the carotid canal. So we start recognizing the structures. And then we have what? We have the tympanic portion of the facial nerve, 7. Then we have the greater superficial petrosa nerve, which is branch of the same facial nerve, starting from the geniculate ganglion. Then from there, we make our triangle, our Kawase areas, then we can access to the petroclival. So the first landmark to be identified, the arcuate eminence, as the dural elevation, advance anteriorly, the middle meningeal artery, you identify them, you identify the internal carotid, you make sure that you don't injure the facial nerve, which has got a lot of branches. Then the greater petrosa nerve is identified, dissect, then you actually reach your area of interest and perform the surgery. This is, I'll end there, and this is what I presented. I prepare for us to share. I think I'll be open to questions and more clarification. Thank you.
Okay, thank you very much, Ali, for giving us a reminder of the transpetrosal approach. This marks the second presentation for today. Okay, so basically for today, post the presentations, we're going to have dissections where we're going to be showing particularly the topic of today, the anterior transpetrosal approach, and be dissecting to the Kawase's triangle, and simulating lesions affecting the anterior clival region. The lesions which affect those areas are mostly meningiomas. Of course, you find that you can access them via the retrosigmoid approach, but if at all they're high up there, it's prudent for a neurosurgeon at least to have a tactical knowledge of these other approaches, and the anterior transpectrosal approach comes handy. Just to summarize what Dr. Ali presented, the key points is, as you're dissecting through your approach of the anterior transpectrosal, the middle meningeal artery will have you flow through to the arcuate eminence. And from there, once you dissect through the dura, you find that you can see the V3 branches, and that one will direct you to the petrous area, the capacity triangle area. And from there, once you drill, you can go straight to the clival region and dissect that anterior portion, the lesion which you're trying to target. So we'll be showing all these dissections today. God willing, we're going to have some time. We'll start first with transpyramidal, then we'll do orbitozygomatic, and hopefully an anterior transpectrosal. So our colleagues from our international colleagues, this marks the end of our presentation. Thank you for joining us. And we'll thank Dr. Bennett and all the international presenters.
Yeah, excuse me just a second. So were we going to try the dissection, or we just can't do it? We're not equipped today, correct?
No, we do not have the cameras.
Yeah, that's fine. That's fine. We'll work on that in the future. But I really appreciate you guys putting the effort to come out and set this up. And you see how simple it is to set it up. You know, you guys aren't experts in setting up, and neither am I. And we got it going. All we used was laptops. We used the laptop. Like right now, you're using the laptop camera. It's no special setup. We have a bunch of people in a room with laptops watching you on the podium with the laptop. Easy setup. So we're all set for our next presentation. So, okay. Thank you very much. And we'll be seeing you at the next webcast.
Thank you very much, Dr. John Bennett. I appreciate it.
Okay. Bye, everybody.